to COVID-19, behavioral health policies affecting children and youth with special health care needs, what to keep, modify, or discard. My name's Helen Duplessis. Next slide. I'm a pediatrician and principal in the LA Office of Health Management Associates. I'll be moderating today's discussion. We're recording this webinar, as you just heard, and it'll be available on the Lucille Packard Foundation for Children Health website in the coming weeks. And I'm ready to go to the next slide now. Perfect. Next slide. We're offering live captioning for this webinar today. You can access the captions by selecting the closed captioning button at the bottom of your Zoom screen, or by clicking on the link that we've just put into the chat function to view the captions. If you're having any technical issues with caption or with anything else, please enter that into the Q&A and we'll try to assist you. The next slide. We have truly outstanding 3 speakers today joining us. Their full bios, I'll refer to you in the promotional materials so we can use the time instead to benefit from their experience and wisdom. Meg Camo will be sharing some additional insights about the effect of the pandemic on behavioral health. Deb Manners is going to discuss some of the service delivery implications from the perspective of behavioral health providers for children and youth. And Nicole Pratt will ground us in the realities of trying to access behavioral health services for her family. Thanks you to all 3 of you and to everyone who's joined us today for making the time to share your perspectives. Next slide. We really want to have this be a dynamic and engaging conversation today. So we'd like to encourage all of you to submit your questions in the Q&A box. We'll be brief with our prepared remarks. Each of us will make some remarks, and then we'll get to as many of the questions as we can today. Next slide. Let's go ahead and get started. So in terms of context, you know, the wide-ranging impact of COVID-19 is really undeniable. And while I think we've all felt it, the effects were arguably felt disproportionately by the poor, by ethnic minorities, and other vulnerable populations, including children and youth with special health care needs. And I should point out today, we're using the MCHB, the Maternal and Child Health Bureau definition that's listed at the bottom of your slide. So what happened in COVID? Well, the federal and state agencies organized a reasonably rapid response to the pandemic through the establishment of legislative and regulatory flexibilities, and in turn, the managed care plans through their own administrative mechanisms. Most of these flexibilities were tied to the national public health emergency. And on the next slide, we were privileged to work, that is to say HMA was privileged to collaborate with the Lucille Packard Foundation for Children's Health on research assessing which of those policy flexibilities actually affected children and youth with special health care needs and their families and their providers. And in addition, we made some recommendations about which policies should be continued after the public health emergency ends. We did this through a detailed review of federal and state policy and through interviews with clinicians, with legal and family advocates, with researchers, program leaders, and other public and private stakeholders. The report, including recommendations that are targeted at different levels of accountability, is available at both the foundation and the HMA websites, and the link has just been put in the chat. And on the next slide, So we're going to start by focusing on some of the really high-level findings and themes. Then we'll briefly go a little deeper so we can stimulate our panel discussion. One of the first findings, as you know, was the real salient focus area of telehealth among those regulatory flexibilities. While most of the effects of telehealth were advantageous to children and youth with special healthcare needs and their families, they also shone a really bright light on the egregious disparities in access to technology and functional broadband. These telehealth enhancements were the focus of a July webinar that the foundation supported, the recording of which is still available on the foundation's website. One of the second findings was sort of a collection of flexibilities in a number of other areas that have also been beneficial to this population. Some of the categories for those flexibilities included things like federal Medicaid funding to increase access, to maintain coverage, and the broadening of the federal match. Another category were the Medicaid eligibility enrollment flexibilities that impacted providers as well as beneficiaries, including things like deferral of redetermination of eligibility, maintenance of eligibility criteria, simplification and deferral of provider applications. We also saw relaxation in a lot of the prior authorization requirements, and we saw broadening in the scope of practice that allowed non-physicians to deliver care and authorize services, including critical services like durable medical equipment, without supervision. And we saw expanded pay to family caregivers, including pay to legally responsible caregivers. So that term legally responsible caregivers in the CMS world, the Centers for Medicare and Medicaid Services world, applies to spouses and parents pertinent to our population. But another key theme of our research was the behavioral health consequence of school closures and unemployment and isolation, and the exacerbation of other social drivers of health, such as access to food, social connections, all of which put really tremendous strains on this population and their caregivers. The next slide. You know, we often get so riveted on the medical complexities of children and youth with special healthcare needs that we forget that they're also susceptible to emotional and psychological stressors and trauma. During the pandemic, these children and youth experienced disruptions in all of their routines. And unlike many of us, they often couldn't exercise any kind of control over those disruptions. School closures meant no opportunity for socialization, and for many, a cessation of critical therapeutic services. Routine visits to doctors and specialists either ceased or were dramatically modified in format and frequency. The lack of respite care, lack of child care and in-home care services, and the massive underemployment affected our children as well as their caregivers. And as previously mentioned, relative to other areas, there was a dearth of flexibilities focused on behavioral health. And, you know, we were largely, not completely, but we were largely caught off guard by this and didn't really anticipate the profound behavioral health toll on children and families. On the next slide, these significant stressors that we've just talked about took a huge behavioral health toll on this population that's gone largely underreported, or at least we've been delayed in recognizing that. That was exacerbated by the fact that routine behavioral health screening in this population is often overlooked under the best circumstances and was most definitely lower priority during the pandemic. And again, the policy options in this area, the policy options for flexibilities were really largely limited to telehealth. So it hardly needs to be stated that the demands and the strain on family and caregivers is additionally exacerbated by all of the demands for 24/7 care in the absence of respite. On the next slide, in addition to the other recommendations in the report, we did make some specific recommendations to support behavioral health for this population and for their caregivers. And I'd like to really, really quickly highlight a few of those. So from the perspective of what could be done at the federal level or by the Centers for Medicare and Medicaid Services, extending that telehealth reimbursement for behavioral health services, especially including on audio-only services, is a strong recommendation. Last week, I should say, there was a rule included in the Federal Register to do this for the Medicare population. And so we're now keeping our fingers crossed that the same rule will be established for Medicaid and CHIP programs. Another recommendation we'd like to see retained is finding creative ways to incentivize routine behavioral health screening for all kids, including children and youth with special healthcare needs. And we'd love to be able to allow reimbursement to pediatric providers to screen caregivers of this population for behavioral health and social determinant needs in the same way that we're currently doing for peripartum mood and anxiety disorder. State actions to take could include some of the same, plus increasing the training and the confidence of primary care providers to deliver behavioral health services. And we'd also like to see made permanent the flexibility in the state of California, at least, to transfer some of our Mental Health Services Administration Act that MHSA funds to meet local behavioral health needs in an emergency situation. And on the next slide, you know, these challenges are all happening on a worsening backdrop of behavioral health issues for all children and youth. So much so that last month, the American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association declared a national emergency in child and adolescent mental health. You can see that prominently displayed on any of those organizations' websites. And I'll point out that on the left side of this slide, those last two bullets underscore the dire circumstances in California, the increases we've seen in our inpatient visits, in suicidal ideation, et cetera. And some of the advocacy recommendations from that declaration are on the right side of the slide. They're similar to the others we've discussed, with the addition of things like sustaining models of integrated mental health care and primary care. That's been a trend that's been moving for the last decade or so. There's also a call to address the ongoing challenge of the acute and inpatient mental health care needs of children and youth. That, in my mind, needs to translate not only into acute community-based beds and psych beds, but to a full continuum of behavioral health services. So with that as background, I'm going to turn this over now to Meg Comeau to share some additional insights about pandemic and what her organizations have been doing. Meg?
Thank you, Helen. I appreciate the laying of the groundwork and especially the detail around the recommendations from the report. I also want to thank the Lucille Packard Foundation for Children's Health for the invitation to be part of this important and timely webinar. As Helen described just a moment ago, we are in a time of crisis regarding the mental and behavioral health of children, youth, and families, and children and youth with special healthcare needs are at particular risk. Pre-pandemic data from the 2019 National Survey of Children's Health shows families of almost a quarter of children ages 3 to 17 reporting that their child had one or more mental, emotional, developmental, or behavioral health problem. Provider shortages, insurance benefit gaps, and high out-of-pocket costs were significant problems before the pandemic and are expected to increase exponentially as demand for services increases now and post-pandemic. Next slide, please, Allie. So I'm going to be speaking today from the perspective of several sources, including the excellent HMA report I hope you've all had a chance to read, as well as the project I've been leading for the past 4 years called the Collaborative Improvement and Innovation Network to Advance Care for Children with Medical Complexity. Children with medical complexity are a subpopulation of children and youth with special healthcare needs who are especially high utilizers of healthcare services, often requiring medical technology. This 10-state quality improvement network was funded by the Maternal and Child Health Bureau and focuses on care delivery improvements that increase the quality of life for children with medical complexity, the well-being of their families, as well as the cost-effectiveness of their care. As part of this project, between 2018 and 2021, we collected both quantitative data via family and provider surveys, as well as qualitative data via a series of family focus groups. Specifically, we conducted 9 focus groups with parents of children with medical complexity in 2019, and the remainder were conducted during the pandemic. So we have data that we can use to compare the experience of families between the 2 time periods. In addition, the Children with Medical Complexity COIN collaborated with the American Academy of Pediatrics on a medical education project focused on the care of children with medical complexity during the pandemic. Learnings from the session discussions, as well as an analysis of participant surveys and focus groups, served as a source of information from the provider perspective. Next slide, please. So I want to preface my remarks by noting that I'm speaking in the past tense here because I'm reporting data collected in the past, but the impacts I'm describing are ongoing. The pandemic and its mental health sequelae for children, families, and even providers are still with us and will be for a long time. The bullet points on this slide highlight select impacts from COVID-19 on families raising children with medical complexity, drawn primarily from the family focus groups, but also from the echo sessions. The whole family's mental health needs were stressed by COVID-19, a need to focus on not just the child with medical complexity, but also the behavioral health needs of his or her typically healthy siblings was also routinely reported by families. Families expressed high levels of dissatisfaction with distance learning, although the necessity from an infection risk standpoint was easily appreciated by parents. One parent described their child's individualized education plan, which had been negotiated over months and with the involvement of lawyers, as being thrown out the window with no compensatory strategies offered. Families described not only physical, but also emotional isolation, as they lost access to many of their pre-pandemic coping mechanisms. Coffee date with another parent, or even a break while children were in school was no longer possible. Families were not only prevented from leaving home without risking exposure to COVID-19, they also lost often their in-home supports and services, such as home nursing. Being on 24/7 with the associated increase in responsibility for medical care, as well as sleep deprivation, had a major impact on family stress levels and their ability to be resilient. Many families describe being in competition with hospitals and even other families for medical resources their child requires day to day, such as gloves, masks, and vent supplies. The emotional distress experienced by families as a result of this change related to their relationship with traditional allies was routinely reported as a significant stressor. The risk of hospitalization was very scary for many families raising children with medical complexity, not only because of the potential for disastrous health consequences of a COVID infection, but also because they worried in the event of care rationing, whether their child would be discriminated against because of the documented misperceptions of quality of life for people with disabilities. They also worried that they would be prevented from being with their child in the event of a hospitalization. Families of children with medical complexity often serve as advocates, adjunct care providers, mental health supports, and patient safety sentinels at the bedside when their child is hospitalized. Next slide, please. The CMC COIN, in collaboration with the American Academy of Pediatrics, hosted a COVID-19 and Children with Medical Complexity Echo lecture in September of 2020, titled Supporting the Mental Health Needs of Children with Medical Complexity and Their Families in the Time of COVID-19. The presenters were Dr. Christina Malik and Dr. Courtney Santucci. This slide describes the major takeaways from their lecture, a recording of which can be found at the link at the bottom of the slide and also in the chat box. It's reasonable to generalize these takeaways from the perspective of children with medical complexity to the broader population of children and youth with special healthcare needs. So all kids, including those with special healthcare needs, should be screened for mental and behavioral health needs. Providers may need to be creative in working with children and youth with special healthcare needs. For example, those who are nonverbal or those with intellectual or developmental disabilities, and interdisciplinary team-based care is optional. Excuse me, not optional, optimal. Therapists should be matched to families' needs and care should be trauma-informed. There's a need to adapt what is working for children with behavioral health needs before the pandemic, not just business as usual, but to really think about it in the context of what's currently happening and what's coming down the pike. Many states and regions have resources for physician support in psychiatry and shared decision-making, especially around pharmaceutical management. Next slide, please. There was a growing interest in and understanding of the need for integrated care for all kids before the pandemic. COVID-19 and its impacts have elevated that need to the point of a crisis. Many of the recommendations made in the HMA paper, including those highlighted by Helen earlier, which are focused on improved and expanded financing of care, can help accelerate the necessary structural changes required to better serve children, their families, and their providers from a holistic standpoint. The American Rescue Plan legislation passed in March of this year includes funding for a 10% increase in the federal contribution for home and community-based services covered by state Medicaid programs. States have submitted plans for using this additional funding to the Centers for Medicare and Medicaid Services. And in a recent blog post, the National Academy for State Health Policy identified 3 behavioral health-related priorities identified by states themselves in their plans, including developing and enhancing mobile behavioral health crisis response options, updating technology and data infrastructure, and investing in the behavioral health workforce. A link to this NASHP blog post with specific details from specific states is found in the chat box. I'm going to turn the floor back over to Helen now, who will introduce the next speaker. Thanks very much for the opportunity to spend some time with you today.
Thanks, Meg. Debbie's going to give us a perspective from a large provider of behavioral health services. Debbie?
Thank you, Helen and Meg. So just a little bit about Sycamores. We're located in Los Angeles County. We are the largest provider of children's mental health. We serve about 14,000 lives a year. We provide school-based mental health services in over 77 schools. And so during the pandemic, we needed to pivot on how we were providing services. Next slide. So in looking at all the services that we provided, and it was mentioned earlier in the slides, the spike in our children talking about suicide. So they had the idea and then they talked to us about it, which, as you know, if you work with children and families and adults, oftentimes they don't reach out and talk about their pain. And so what we saw really quickly after the stay-at-home order was issued in March was a spike in talking about suicide. So just to do a comparison, we were prior to the stay-at-home order, there was about an average of 16 suicidal thoughts reported per month, and then we saw a spike in 23. So that's an average of 44% increase. Next slide. So in the months leading up to the pandemic, we saw about an average of 2 suicide attempts. And then during the pandemic, again, 100% increase in a spike in 4. So we have a mobile response program. So we have staff who go out into the home and try to do hospital diversion, crisis stabilization, or they will find a hospital and hospitalize the youth. One of the other things that happened during the pandemic was there were no ambulances available for transportation to the hospitals. And so sometimes the wait could be 8 to 12 hours. Next slide. So looking at the 47% increase in psychiatric hospitalizations, what that really also doesn't really address is how many we were able to stabilize while we were waiting for an ambulance. So during the pandemic, in addition to seeing a spike in psychiatric hospitalizations, The other issue that we really dealt with is because many of our youth are under the jurisdiction of the Department of Child and Family Services. So we really felt the need to do those services in person. And so in retrospect, now that we are returning back and doing almost 100% of our services back into the field, we've really started talking about what an impact that had in the fact that we were continuing to do a lot of our services in home, and mostly because we had issues with our families having access to devices and broadband. Next slide. So if you look at our services, you can see that during the first 3 months, 20% of our services were delivered in person, and then we really have increased. So our services really span. So I talked a little bit about, we have our school-based services, we have our intensive in-home kind of wraparound services, and then we also have a homeless program, which continued to be in person 100% of the time. And then we also have a residential treatment program that of course was also 100% of the time. Next slide. So the spike in mental health services, and we continue to see this spike, was a 32%. We continue to see a spike in services. We are unable to meet the demand currently because of workforce shortage issues. We've looked at our turnover, it's about 30%, one of the highest we've ever seen in probably, well, the 30 years I've been here. And so that's really affecting access to care. So from a kind of system of care service model, we're really talking about how do you kind of begin to triage. And we did a little bit of that early on in the pandemic, but we're continuing to see the need to do that. Next slide. So during the pandemic, it was important to us that we made sure that we were meeting the needs of the kids and the families that we were working with, that we were able to provide good quality care, and that our employees felt like they were doing meaningful, effective work and getting good outcomes. So we continued to do surveys of our staff as well as our caregivers, and then our community partners, who are really the schools, Department of Child and Family Services. And you can see from this slide that 90% of our caregivers were satisfied with the service. And a little bit about our services: we have peer support, we have parent partners, we also have youth who have substance abuse issues or who grew up in the foster care system. And so they really work as part of that team, and we're really there to support the caregivers during this time. Our staff, who really were, many of them are in their 40s, they had children at home, and so they were really managing, homeschooling their youth and doing telehealth, and then going out into the communities and providing services in the evening. And so wanted to really make sure that they were doing well. We made a decision at the beginning of the pandemic that we would keep every employee employed. And we also started a COVID relief fund so that any of our employees who maybe had economic issues or lost a loved one, they could apply for some economic relief from our organization. And then we surveyed our community partners, and 90% of those felt like they would continue to refer their consumers to our services. Next slide. So I'm going to turn it over to Helen.
Very good. Thank you so much, Debbie. We'll hear from Debbie and Meg in just a little bit, but we want to hear from Nicole, who you'll see her virtual background aptly lays out what she's been up to. But we want to hear from the family perspective. Nicole?
Yes, hi, good Good morning over there. Good afternoon where I am. I'm Nicole Pratt. I live in New Jersey. I work for the Parent Center here in New Jersey span, but I'm here talking to you from my parent hat today. As you see on the screen, I'm a single parent of 2 young adults now. I have a daughter who is now 27, who just graduated from her college this past May, but when she was a teen, dealt with mental health services. And one of the things I thought about when the pandemic hit, even though she's been stable for 7 years, how is the pandemic and going to college at home going to affect her? Because socialization was one of her big things that she greatly improved upon over the last couple of years when we moved from one part of the state to another. And I would have several conversations with her about that and how she was feeling, and, urge her to contact the mental behavioral health services that her college offered. And now I'm going to talk to you about my son, Jordan. And so Jordan has a developmental disability. His diagnosis is mild cerebral palsy with a neurodevelopmental delay. He just turned 21 in July. He just graduated from his high school because he went through 21 and now is being serviced through the developmental disability system. But Jordan had been getting mental health services actually for the last 4 years. 3.5, 4 years at school due to the loss of his grandfather a couple years ago. And it was important because I saw that he was having, some bouts of sadness and some issues hovering over depression. And then when the pandemic hit and his school went virtual, for the first couple of months, he was okay. And then after a while, it was really affecting him even more. And so I had a very good relationship with his counselor at school and would communicate with her because he was voicing that he was really sad and he wanted to go back to school and things like that. So I kept really close touch with his counselor at school. And then when graduation was coming upon us, in this past June, I said to her, because he was still having bouts of sadness about his father, even though they went back to school part of the time, and he was still having some sadness and feelings about not really being in school the way he really wanted to be. So I asked his counselor and I said, do you think I should still continue behavioral health, mental health services? And she goes, definitely, he definitely needs it. And it's really been a big help to him. I said, okay. So about 3-4 weeks before he graduated, I put my mom advocacy hat on and started looking up his insurance. He has the Medicaid HMO here in New Jersey, and I started researching, and I started looking at the mental behavioral health organizations that were listed under his insurance, and I made sure that they said that they service young adults, children with developmental disability, because that was really, really important for me, that I had a service provider that also understood his developmental disability. So I start calling, one place didn't call me back. And then I get in touch with another place who I was familiar with their name. And I was like, okay, I know who they are. And so I call them, and the ladies, I explained to them about my son, and I explained to the lady what I'm looking for. And so the first lady, they answered the phone and says, well, I don't know if we service, people with disabilities here. So I sat and I was like, my eyes were bulging out of my head. She didn't really see me, but I was sitting there for a second. I was like, she really doesn't know who she's talking to by telling me this. And I said, well, let me speak to the supervisor. Let me speak to your supervisor. She's like, oh, okay, hang on. But what she did was hang up on me. So what did I do? I called back. So I called back and I said, you hung up on me. No, I didn't. I was like, yeah, you did. Let me speak to your supervisor. So she must have said something to the supervisor. So when the supervisor got on the phone with me, she had kind of an attitude, and I explained to her my situation. I said, my son is going to be graduating. He does have a developmental disability, but he's able to facilitate conversation, and I need to have him continue mental behavioral health services. So she says, well, I need to speak to him. I said, well, you can, I said, but the information that you need, I need to support and speak on his behalf. Well, we can't provide him any services if we can't speak to him. I said, well, I'm his mother and I'm providing support to him. So are you telling me that you're not going to service my son? She goes, well, I don't know if we're going to be able to service him there. I said, oh, so you're telling me that you're not going to be able to service my child? Is that what you're saying to me? I said, that is discriminatory. She's like, no, it's not. I said, yes, it is. I said, you say on the information that you service individuals with developmental disabilities, but here you are telling me you can't service my son because he has a developmental disability. I said, that is very discriminatory. And so then I hung up because I knew I felt myself going somewhere else. So then I went through, plowed through, kept researching his insurance, and found we have an ARC here in my county. We have ARCs in every county in New Jersey. And so I was like, oh, okay, they have a behavioral health service program. So I called, and it was great because, I knew that they would more than likely provide service to him. And that's where ultimately I was able to get the behavioral health services, which is being paid through his insurance for my son, which he gets once a week through a telehealth model. And then he also gets to see the clinician every 3 months just to keep updated. And so, with all that and going through all that, I'm a single mother. I have my own health issues. I have survived domestic violence, when my children were younger, working with families and supporting other families with the work that I do at SPAN. I was beginning to feel very, very overwhelmed and stressed. Extremely. And I started talking to some people at work. I was like, you know what, I think I feel like I need mental health services. I said, because, just keeping my children healthy, keeping myself healthy from not getting sick, working. I love the work that I do, but I also know that I have to take care of my mental health and take care of my health in order to be here to support my children and to provide support to other families. So I say that, as parents of children with disabilities or mental health or special health care needs, we have to be our advocates for our children, even when they are young adults. Right. And also remember to take care of ourselves and take care of our mind, take care of our body, and take care of our hearts, which are our children. So thank you. And thank you for having me here today. Oh, you're welcome.
Great. Thanks so much, Nicole. That was really wonderful. We've got plenty of time now to open up the webinar for questions. There are a number that are already in the Q&A box, and we'll be going through those. So just a reminder, if you have questions, enter them into the Q&A box. While we're getting to those, let me offer one that is sort of a lead-in to one of the questions from the Q&A box. We spoke about the dire situation of our behavioral health system for children and youth in general, but especially for those with special healthcare needs. So I'm asking now the entire panel, are there opportunities you're aware of on the horizon? And what can we do to advance those opportunities to see to it that something is done to address what is obviously a huge mismatch between the need for and the supply of behavioral health services, particularly for children and youth with special healthcare needs? So I'm opening that up to the panel as a whole. Meg, do you have a thought?
I do have a couple of thoughts. So specifically, most of this kind of work happens on the state level. So there are federal supports that are available, and I think they get a lot of attention, but it tends to happen more on the individual state level. And so expanding pathways to coverage, whether through private insurance, mandated benefit laws, or through Medicaid, expanding access to Medicaid, especially through home and community-based service waivers, is one way to address benefit issues. Another thing to think about, though, is to look further upstream and see if there are things that can be done in the area of the workforce. So enhanced reimbursement for services provided, reimbursement for training, and professional development education are really important. I think another thing that is less recognized, though, is training for families as well, and education for families as well, which can be incredibly important in terms of making sure that the entire family is looked at holistically, not just the individual child with their individual mental or behavioral health problems, but they're seen as all of health is included in the thinking and the strategies, and the entire family is included in the thinking and the strategies. Those are just some thoughts off the top of my head.
Deb?
Well, I keep thinking about the role of the school, because that's where kids end up at 5 years old and sometimes sooner. And so what role they have in really just doing screening and assessment. And also having behavioral health providers located at the school. So even if there's an assessment that's done or a screening tool, then there's not a linkage and referral, but it's actually a warm handoff. So they make sure that there's some services that are provided and that they include the family. And so once there's an assessment done of the child, then the assessment or the screening goes out to the family as well, because it really, I think as Nicole stated, it's really the whole family, and mental health issues it affects everyone. And so I really think the focus needs to be right now on the schools. And as kids are returning back to school, we're seeing that the schools are overwhelmed with what they're finding in the children as they're returning.
Yeah, good point. And Nicole, I know you have a comment, but I'm just going to tie Deborah's comments into a couple of questions that came up in the Q&A box. One from Bethlyn that you've addressed, Deborah, about behavioral health screenings. She asked the question about through school nurses, but there are a whole host of personnel within the school system, including school-based health centers, as those are accessible on campus, who may be engaged in that. And then Michael Butler also asked a question about how the ongoing expansion of school-based mental health might provide a partial solution. Any additional comments related to that?
Well, I think someone also put in the chat that schools are overwhelmed, and we're seeing that in the schools where we're providing services, and we're really, what we found out to be most effective is to be integrated with the schools. So the kids and the staff and the families would never know that our staff aren't school staff, right? And so the ability to be there and to really work as a team is really important to support the teachers and to support the administration. So that's the other role of school-based mental health providers, is to really kind of educate everyone on what is it that you need to be looking for in your classroom, and what do you need to refer immediately for screening or for assessment.
Sure,
So I just
absolutely, Nicole.
To that, and I saw someone put that in there about the ERISA fund. So in New Jersey, a few years ago, because they kept seeing a spike of children with mental health even before the pandemic, a couple of school districts started to partner with community-based mental health places, because one, parents were struggling to get an appointment with a psychiatrist when they made the call that say your child needs to be clearance, right? Or the insurance, they couldn't afford it because many psychiatrists don't take payment, or you couldn't get a community-based one from the hospital because you have Medicaid and you had to wait. So what some school districts started to do was partner with mental health agencies to get the children screened. So now you fast forward, you got a pandemic, everybody's home, and now everybody begins to come back. And so what we did at SPAN, we had a short summit over the summer, and we invited the Department of Ed in to find out how are they spending their ERISA funds. And one of the things, even though there are many schools that already had social emotional programs, and so the ERISA funds now has been able to, and they have to apply for it, to be able to enhance what schools already had or schools putting in social emotional learning, which encompasses more mental behavioral health supports in school. So that's what's happening in New Jersey, but the issues also still arise with insurance, right? And so if you have private insurance, trying to find a psychiatrist or a mental health provider that you can afford. And then if you have a Medicaid-based insurance, HMO, well, then you're kind of pigeonholed into which ones you can actually go to. Many of them, whether they're community-based mental behavioral health services or, through a hospital-based program. And so there's definitely, I think Meg pointed out that the advocacy is at a state or national level, right, to ensure that there's more funds and going in, and if there are any bills are coming up. And that's really important. That's why it's important that parents and everyone and professionals tell the story. And so to ensure that people hear what's going on, lawmakers hear what's going on, to say, oh, okay, we need to put more money in every year we always hear we're going to put more money in mental health services. Well, it's still not enough. And so we still have to keep telling our stories. We have to advocate, whenever we can. So I think that's really important that we keep getting the stories out there, and parents not being afraid to tell your story, right? Because that's what makes a difference.
Yep. Yep. And I'm seeing a number of people in the chat and in the question have talked about the long wait lists for waiver services and other kinds of services, and how significant that is. And I think you're absolutely right. Got to keep telling those stories and keep pushing. Absolutely. Couple of questions too, or comments. And I'd love to sort of throw out, where does primary care fit into this? Are pediatricians part of the solution, or other child health providers part of the solution to the behavioral health service crisis? And what needs to be done to best position them to be part of that solution?
Well, definitely, pediatricians are part of this, because oftentimes what they can do is do, again, a screening, and then work with the family around kind of what the issues are, and then helping them to get some treatment or some type of intervention. It seems that in many situations, family members are, I think, more comfortable talking to their pediatrician than they are with someone else.
So one of the things that I think about when I think about the role of pediatricians is so many of them are overwhelmed with all kinds of different things now, but those mental and behavioral health needs land on their doorstep anyway. And so the need to provide more interdisciplinary support around them, if they're practicing in the context of a community-based medical home, then being able to have resources around them that can help support the work that they're doing with patients and families is integral to being able to improve the quality of care and better outcomes. I think one of the things that I mentioned was to have consultation services available. So child and adolescent psychiatrists who can help community-based pediatricians with pharmaceutical management is really a helpful thing. It increases the confidence of community-based pediatricians to be able to provide good quality care to these kids. And it's a patient safety issue, but it also helps extend that workforce a little bit in ways that can be important.
Yeah, and I'd like to share that, I mentioned in my earlier comments that the move to integrate behavioral health and primary care is over a decade old now. The reality is it's been a little slow coming to child health care. And indeed, the notion of having in-house services with social work and other therapists and even paraprofessionals who can provide support, other parents, et cetera, who can provide support and be some of those wraparound services and facilitate the connections to and navigation through the systems and referrals to the degree that they're accessible, and pushing on those wait lists as well is really, really vital. We've sort of gone from sort of the old school community pediatrician that did everything to now, in the advent of managed care, very focused anticipatory guidance, acute and chronic needs focused pediatricians. And now we're sort of moving back almost full circle to that holistic approach that is at the bedrock of child health care. Lots of important conversations. Here's kind of a disturbing one. Jerry Clark made a comment about the trend of families being coerced to give up custody of their kids in order to access optimal services, particularly for impaired kids. Can you all comment about this trend and what can be done to stop it?
If it's okay for me to jump in for just a second.
Please.
This is not a new phenomena. This has been happening for a really long time. One of the drivers behind it is that kids in foster care are automatically eligible for and enrolled in Medicaid. And Medicaid through EPSDT, the child health benefit, pays for mental and behavioral health services to a greater extent than private insurance, and certainly being uninsured does. There are several strategies that states use in order to try to mitigate some of this risk. One is to pass state laws that prohibit this kind of situation from happening to begin with. Another is voluntary agreements between families and the state that the family will retain legal custody of the child, but the child will be eligible for Medicaid services under the Medicaid plan. Another is around states really devoting specific time and attention to increasing the workforce. So looking back upstream, not waiting till the kid's in the river drowning, but trying to keep them from getting into the river to begin with, increasing that workforce and really having enhanced reimbursement and funding for training so that there's a there in order to meet the need before it gets to a crisis state. And certainly expanding access to Medicaid through pathways such as home and community-based service waivers. You have to address the issue of waiting lists around that, but that's another way. Medicaid buy-in programs is a potential state strategy that can be used to expand eligibility for Medicaid for kids so that they can get into services, they can get screened early, they can get treated early before it becomes this crisis state where their families have to look for external help in getting them the services they need.
Nicole, did you have a comment about that?
So I do know that does happen, and regarding to with the Medicaid. So Medicaid is a really big issue, and every state has a Medicaid program. And, and I was reading a comment about the one mom talking about the Medicaid waivers and not being able to get services. And in New Jersey, we have a system of care, a statewide system of care, which has been now around for about, 16, 17 years. And it's a program that has morphed and changed over time that provides in-home behavioral health services for families and children, and for children in the child welfare. So they try to avoid not taking the child away from the family if the child needs those services. So the first thing they do, they want to ensure the child welfare system ensures that the family is getting all the, if the child's ending up in the DCF system, but the family is getting the services pushed into the home. If it's access to services, maybe the family is struggling to be able to, make the call or a variety of other things that could be going on. And so the system here is set up to ensure that the family is getting the supports that they need, and then child gets supports. Now, if the family is unable to, then they may look at then they'll look at possibly removing that child. But that in New Jersey, they've made it the last resort. It's been a long-standing thing to change that way of thinking, to keep children out, not pulling children out of the home, but with the parent or another family member. So I think each state from what I'm reading, people were saying what they have is very different than how those systems look like, especially around mental behavioral health services for children and for families. And so again, it goes back to that advocacy piece, when Medicaid has hearings, if that's something in your state that is happening, then why is it we're not looking at ensuring that the families are getting the right support services, instead of saying to a family, well, why don't you just give up your rights, which that doesn't necessarily have to be the case. It's really about getting that family the right supports and services. Yes, definitely.
Yeah, great. Thank you for that.
Um,
Just shifting a little, I know I love the comments. There's so much to talk about. We could have scheduled this for, I think, 3 hours and still not have enough time. One of the other questions that came through was about, we're sort of back to workforce and integration. So what are the fiscal barriers to integration of behavioral health with primary care? And I'd like to offer some additional thoughts about that and then encourage others to add to that. Clearly Meg's underscored the notion of low reimbursement rates, and that combined with stigma is an ongoing challenge. In the safety net, particularly in federally qualified health centers, rural health centers, there are proscriptions against same-day billing for more than one kind of visit. So if someone comes to see me as a pediatrician in a community health center and I make a referral to the psychologist or the psychiatrist who is also part of our center, we can't bill for both of those visits. We're only allowed to bill for one visit a day. That is a huge, massive disincentive. I think the other challenge too is, and I'm going to own this as a physician, but it is a larger health system challenge. Is we alluded earlier to the notion of needing to think more broadly about who can provide behavioral health supports and services. It's not just physicians, it's not just psychologists, being able to really train and utilize an increasingly effective paraprofessional and peer workforce, not all of whom are recognized and or allowed to bill. So other thoughts?
Well, I'll just say we hired our first parent partner in 2001. And we have had a robust peer support program. In our residential program, we hire youth who grew up in foster care or who were in the probation system to work with our kids in our residential program. And what I love about peer support is their ability to do engagement. And as you know, if engagement is opening the door. And it's just so important. And we, now in California, peer support is recognized, but they can bill Medicaid, Medi-Cal, and they've been able to for as long as we've employed peer support. And so it should not be an issue, but they are incredibly valuable, especially when we're working with families who do not want anyone to know they have a child who has a mental health issue.
Yep.
And they don't understand it. And so they'll talk to the parent or the teenager before they'll talk to the psychiatrist or the psychologist or the social worker.
Meg, if we have a minute for just one more comment.
Sure.
Debbie, I think if you're hiring paraprofessionals from the community, it can also address the issue of cultural humility and cultural accessibility for folks. And so I think that's incredibly important when it comes to the effectiveness of the treatment of the service provided, as well as improving the outcomes.
Mm-hmm. We have we have a family resource center in a community, and we hired people from the community to be health promoters. But we knew that what we really wanted to talk about was mental health, but because of the stigma, we started talking about physical health.
Yep.
Yep.
And I
just add that peer support, we do that here in New Jersey on a variety of different levels. It's part of our system of care. You know, they have the clinician, but the peer support. And as you mentioned, it's such a critical piece, right? Because that person, you know, I may meet a parent and I'll tell them parts of my story. And then at that point, once I've talked to them, they may be like, maybe on the fence to contact a clinician. But after I've shared my story and given that support and say, this is how we can do this, and I can help you with that and help you through that. And it's just better, right? It's more culturally effective to have someone, not that the professional is not, but sometimes having that family or that person or that youth has kind of been there and gone through it, to be able to talk about the experiences, and if it led them to getting those professional services is so critical and so important.
Absolutely. Well, my goodness, that is all the time we have for questions today. We are going to make every effort to address unanswered questions and provide that information to you in printed form with the rest of the materials. If you'd like to read the full report that we referenced today, we're putting that link back into the chat yet again. And I would encourage you to visit the foundation website to learn more about their work with children with special healthcare needs and access resources. And I also just want to thank our panelists. You all were wonderful, and everyone who joined us today, and wish all of you continued support and empowerment in carrying out the good work that you all are doing. Don't stop. We got to keep pushing. This is a huge issue. Have a great day, everyone. Thank you for your participation.
Thank you.